Hi, this is Dr. Bob Dannenhoffer. It's the last day of July, and we're going to be doing our Facebook Live update. This is a time for you to ask questions. Put them in the message section there, and we will take a look at them and get back to you. We try to answer all the questions tonight, but if we don't, I'll do that later. I'm going to take this down. This is my new balaclava. I got this at Lowe's. It's actually kind of nice. And so whatever face covering you wear, just wear a face covering, whether it's a face shield, a homemade mask, a surgical mask, any of those work fine. So we're going to talk today, as we normally do, starting at the beginning and starting at the worldview about what's happening. And this is still a very, very active pandemic. We're now at 17.5 million cases worldwide and almost 700,000 deaths. You know, July has been a very steep month. We've had 7 million cases added just this July. And over the last few days, we've had over 250,000 cases a day. So this is a very, very active pandemic worldwide. We're seeing lots of activity in the U.S., lots of activity in Brazil, and lots of activity in other countries in South America. So Chile and Peru and Ecuador are really having lots of cases. In Africa, South Africa has had the most cases. In Europe, it's pretty quiet, but all of those countries are seeing cases. There's no country in Europe that's really licked this. And the UK, which released restrictions about a month ago and encouraged people to go to bars and such, is now seeing a resurgence, and they may need to move back. In Asia, China's still pretty quiet. Taiwan is quiet, but Japan has had an increase in cases. Australia has had a marked increase in cases. And so that's a problem. However, New Zealand is still doing well. Taiwan is still doing well. South Korea is still doing well. So there's glimmers of hope out there, but there's still lots of disease. In the U.S., it's still also very active. We're at 4.7 million cases, 156,000 deaths. Just today, there were 70,000 cases, so over 200,000 cases in just the past 3 days, and 1,500 cases today. I mean, that just is a stunning death rate for an infectious disease in July. Still very active in California, Florida, Texas, and Arizona, but we're also starting to see more activity in Alabama, Georgia, Tennessee, and Kentucky, and so this is a big concern. In Oregon, we continue to have 200, 300, 400 cases a day. Today there were 373 cases and 6 more deaths. And while we look at this and say, oh God, this is awful, I think what people don't realize is that Oregon has the 6th lowest attack rate and the lowest attack rate for any state over 2 million. So it's a little hard to know what to do with Montana, Alaska, and Hawaii. But if you take states that actually have reasonable sized cities and suburbs, we're far and away the lowest in the country. I don't know how we quite do that, but we're one of the lowest, and our death rate is one of the lowest in the country. So although this does seem like an awful lot of disease to me, in comparison to my brethren in other states and other counties, it's a lot less. We had a really high week last week with lots of cases. This week has been quieter. We've had about a dozen cases over the last week, which is a pretty low rate. It's still higher than we were in April and May, but it's a relatively low rate. And our testing percentage, which had been over 5% positive last week, is now down about 2% positive, which is just where we want it to be. So this has been a good, quiet week for us. However, when we look at cases, there are a couple of things that are just recurring themes. The first is travel from another state. Again, almost half of our cases start in another state and it gets brought in. So if people are traveling to the state, really be careful. Unless you have an incredible time crunch, please quarantine for 2 weeks before you get here, and then 2 weeks in the new state. Again, if people had done this, we could stop so many of these outbreaks. The second thing we're seeing is people going to work when they're just a little sick. Well, I mean, most people probably who are just a little sick have something else, but almost all the cases we've seen have been, I just went to work when I was just a little sick, and that really is a big, big problem. And then gatherings. And these are parties, these are weddings, these are family reunions. All of these things have been really associated with spread. And again, we want to get our rates down because one of the things we'll talk about, I'm sure later on, is about schools. And in reopening schools, we have to have the rate low to open schools. And the rate needs to be pretty low. It's got to be as low as it was we had back in April and May. I think with the level of disease we have now, if we'd open schools, you'd have outbreaks. And with outbreaks, that would be a problem. So we really got to get the rates down. Okay, so we already got a lot of questions. Yeah, so Sandy says, how are some schools moving forward with opening and others aren't? I thought the whole county had to meet the metrics. Yes, the whole county has to meet the metrics with some tiny exceptions. And so there are some schools who are just saying, look, we're just not going to open in person for a while. There's others that say, if it is safe to do it, we will open in person sooner. I think both of those moves are okay, but all schools, whether they be private or public schools, need to follow the rules. So Desiree said, I heard a nursing home in Oregon had a bunch of false positives. Have you ever heard about that? I haven't. So Desiree, if you could tell us where that was, I will track down the health officer in their county and see. We've had a lot of places where there have been nursing homes with positives. I haven't heard they were false positives. So Nicole says, why is it taking 10 to 14 days to get results? And I ask you, Nicole, why the hell is it taking why is it taking 10 to 14 days to get the results? This is maddening to us, right? So somebody does the right thing, they get tested, they wait their 14 days, they go, and then we get the results at the end of the time. This is totally, totally, totally unacceptable. And there are reasons. So here are the reasons. The reasons are that we have a certain test capacity in this country, and the test capacity is pretty high, but with so many cases in California, Arizona, Texas, and Florida, 4 big, very populous states, they are demanding many, 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 many tests every day. Remember, you're supposed to do 50 tests for every positive. So when Texas has 10,000 cases in a day, they should be doing 500,000 tests in a day, and there's just not the capacity here in the country. And some of the capacity in tests gets moved from place to place. So when we look at tests done for Oregon residents, only about half are done in Oregon, and the others are done in national laboratories. And then what happens in the national laboratories is the national laboratories get behind, and as these national laboratories get behind, specimens get delayed. That is totally unreasonable. You should always be able to get the result by the next day. But some of the big labs have said, look, there are a couple of problems. One is there's shortages of stuff. And the shortages of stuff are these little pipette tips, these little plastic tips. You wouldn't think in the world that there could be a shortage of these, but there is. There's a shortage of reagents, which are the chemicals that you need to put in there. And then machines themselves, if you've ever seen them, they're about the size of a refrigerator, and they've got a zillion little moving parts in there, and you put the stuff in there and it sucks stuff up and moves things around and whatever. Well, these machines only run so many cycles, and in the past, many of these places had a machine and they'd run a cycle maybe every day or maybe every other day. Now with COVID, they're running 6 cycles a day, and these machines are being pulled out either because at their end of life or because they're needing maintenance. So Quest, which is one of the big laboratories in the country, was really able to build up their capacity from just a few hundred tests a day to hundreds of thousands of tests a day. But they said that they're not going to be able to build it up much further because some of the machines they used early on are coming offline, and their ability to buy new machines and get them online is limited. So we are going to have troubles with long testing, and this is a problem. So are we having lots of requests for COVID testing for asymptomatic patients? We're not really. There was a time there where we had adequate testing and we were getting for a lot of asymptomatic patients. One of the big requests now is for asymptomatic patients who are undergoing surgery, and that is actually drawing a fair amount of test capacity. But other than that, we've been not getting lots of other requests. So Sandy says, well, not to blame, but if we hadn't had the outbreak at Norris Farms, would we have been able to open schools? So we would not have been down to the 10 level to open all schools. We would not for that 1 week have been over the 30, but actually that week of 30 is not going to make a difference because none of the earliest school date is the 25th of August. And so we're still more than 3 weeks from that. And we met it this week. So the Norris Farms will not impact any schools opening. However, the continuing outbreaks now will. And, we would love to be down to the 6 or 7 cases a week so that we could open all schools. But to do that, we really have to have people be careful about travel, be careful about gatherings, be careful about going to work when you're just a little sick. So for schools, how is the K3 metric different than the 412, and do they have to meet the same metrics? I was deeply involved in this, so it is confusing. So the thought was that K3, the benefits of K3 education are higher than the benefits of later education, or the benefits of in-person education. Because in K3, kids are learning to read. You really can't learn to read online. You can't really read a book to teach you how to read because you don't know how to read. And so in the first 3 years, it's felt that the benefits of being in school, learning to sit with other students and work with other students, and how to read is really important. Whereas by 10th grade, you probably could do biology online. The second thing is data suggesting that kids less than 10 are much less likely to spread disease than kids who are over 15. And so for those are the reasons that there are more lenient guidelines for K3 than there are for 412. So the K3 guidelines are you have to be under 30. The 412 is you have to be under 10. We're under 30. We're not going to be under 10 unless we do a little bit more work. So Roberta says, we had a lot of people from our state for the non-graffiti week, yet no huge increase. Why? Well, I think we probably had 1 or 2 cases related to, that might have been related to that. It's always hard to know. So it's not like you get a receipt when somebody gives you coronavirus, so you don't know. But what you do is you look back to the time that people were likely infected, and usually we can lay that down to 1 or 2 days. But over the space of 1 or 2 days, you may have had a bunch of different gatherings. There were maybe 1 or 2 cases that might have been related to that, but graffiti again was outdoors. There were not a lot of indoor things with graffiti, and we really think that indoors is hundreds of times more dangerous than out of doors. So again, when people talk about doing things out of doors, I almost never say no. Now, the one thing that you would be cautious about outdoors is people very close together who are yelling and shouting like the protests. Although we've not had a lot of that in Douglas County, and I don't think we've had any cases that we've associated with that. But that is a real worry for the rest of us. Or even outdoors at a ball game, like at a baseball game, there'd be a lot of people really close yelling and screaming. But again, I think the graffiti week or the non-graffiti week was safe because, again, it was mostly outdoors. Do I know anything about controversy about the 26-year-old death? Family says it wasn't COVID. I don't know. I'll look it up. And again, if you can give me more details, this obviously not a Douglas County death. Are you talking about the Yamhill County death? And if you are, let me know, and I'll look it up. So Monica says, will DOE include the presumptive cases each week when trying to decide to let districts open? I believe they will. I think they're going to look at all cases, both presumptive cases and confirmed cases. Although when you look at our number of presumptive cases is way down because the state has now, there's a new test out there called the antigen test, which is much quicker. And so many of the cases that in the past stayed presumptive for a while now get confirmed more quickly. So if you look at our number of presumptive cases, only just a few, and I don't think that's going to really change things very much. The trouble with presumptive cases is that many times in presumptive cases they then become confirmed, and so it's really hard to separate that out. So the state just considers the total, and I think that's the right thing to do. Okay, so one of the things I want to talk about is blood type. Remember we talked in the past about blood type. There's some early studies that suggested the O blood type was a real risk factor for worse disease, and A was a bit preventive. So they looked at that more. As you get more and more cases, you get more and more people looking at it. And blood type still probably makes a difference, but the difference is much less than was originally thought. The second thing is hydroxychloroquine. What would a week be without talking about hydroxychloroquine? So hydroxychloroquine was one of these drugs. It's used to treat malaria. It's used to treat lupus. And early on, the Chinese tried it to treat COVID. They didn't think it helped very much. And then over this time, it has gotten just amazingly politicized. I never thought a medicine would get so politicized, but it's so politicized with people who are just screaming and neck veins bulging about hydroxychloroquine one way or the other, either that it works or that it doesn't. I really haven't had my heart rate rise at all about hydroxychloroquine. I've just looked at all the studies. And there have been a bunch of studies. There was the original Chinese study, which wasn't that good. But then there was a very good study from the UK, a good study from the US, and now a very good study from Brazil that suggests it really doesn't help much. There was one study from the UK suggested it hurt. We haven't seen much of that. There's one study from Henry Ford Hospital that suggested it would help, but I carefully looked at that study this week, and it's very problematic. It's what we call an observational study. Hey, we tried this, and this is what happened. And it turned out that the people they treated with hydroxychloroquine died at a lower rate. However, if you came in the hospital and had any heart stuff, they didn't treat you with hydroxychloroquine because of the risk of heart disease. And if you were really sick, they didn't treat you with hydroxychloroquine. So the people who got hydroxychloroquine tended to be less sick, younger, and less heart disease, and you'd think they would die less. So it's a reasonably interesting study, but certainly doesn't prove that hydroxychloroquine works. And I think the best data out there is, unfortunately, it doesn't. I would love for it to work, but unfortunately it doesn't. There's this Dr. Emmanuel who has been saying, it really works, she has 100% success and whatever. And what I say to those people is, please just publish your studies. Or let somebody else come in and review the records. So before all this COVID stuff, I did a lot of time reviewing records. So people would make claims or whatever, and because I'm sort of an old guy with a lot of gray hair, they would have me come in and review the records, and I would review the records and make a report based on what I found. If this really works that great, just open up your records. Let somebody like me come in and take a look, check to be sure that this is all done and done correctly. This would be a great paper to publish. I think standing on steps and screaming about it doesn't help any of us learn. I hope it works, but I just don't think it does. So Allison says, do you think the attitude that this isn't real is keeping mildly symptomatic people from getting tested and thus not representing true numbers of cases? Well, we clearly think that there are people who have this disease who aren't getting tested either because they're so mildly symptomatic or asymptomatic and don't even know they have the disease. And then there are other people who are just denying it. I cannot tell you the number of people we have. I just thought it was allergies. It's like, you don't really get a lot of allergies in mid-July unless you're allergic to something in mid-July. Or I just thought it was a sinus infection. It's like, ooh. And so they've denied it and continue to work and continue to spread it to people. There clearly is some reluctance to test, but I think probably in Oregon we're catching probably 30 or 40% of cases, which is about as good as anywhere. Did I misunderstand? Did you say type O was high risk? Well, what I did say is that in the past they thought that, but I think what the thought is now, if there is a difference, it's much smaller. An update on a vaccine. Again, what would a Friday be without an update on a vaccine? So there are a bunch of vaccines. I think there are 70 trial vaccines out there. There are 21 that have made it to human studies and 4 that have made it past phase 1. And so phase 2 is a bigger group. Phase 3 is a really big group that you're studying and carefully looking. So the Moderna vaccine started in phase 3 trials last week, or early this week, and the Oxford group is going to start on theirs in September. So phase 3 trial, 30,000 people who get the vaccine, 30,000 people get the placebo. They very carefully on those 30,000 look to see if there are rare side effects, neurologic or other side effects, and they look at the rate in each group. So if the rate in the treated group have one side effect much more than the control group, you have to worry that the side effect is from the vaccine. On the other hand, if there's a side effect in the vaccine group, and you look and you say, well, it's the same in the other group, then it's probably not from the vaccine. And so that's what they're doing. And they're also going to look to see, of those 30,000 people in each group, some are going to get exposed to the virus over the next few months, we would think. And if they do, the question is, are they prevented or not? So again, let's say that of the 30,000 in the group, 1,000 get exposed in each group, and of the people in the placebo group, 1,000 people get the disease, but in the treatment group, none get the disease, that would suggest this vaccine is very effective. I don't think it's going to be that good, but the hope is that, if there's 1,000 in this group, it would be less than 500 in the treated group. Yeah, so Ashley says, how long until the guidelines or quicker, easier tests available to all of us? I'm really hoping so. You remember for months now, I've been hoping for the little saliva test. You wake up in the morning, spit in a cup, have the results in 10 or 15 minutes. We are told that we're getting closer and closer and closer to that test. But there have been so much hype about testing that I will believe it when I see it. When you look at what's needed to make that test, I don't think we're that far off. I mean, I don't think, we know what the protein is. We know what the antibody to that protein is. You can do an ELISA test. You can put all this stuff together. So I don't think we're that far off. And that would be a good thing, because if you had that and a test that may not be perfect but pretty good, and everybody could do that 3 times a week or even every day, and even if you found 50% of the cases, you could drop the transmission rate by half. And if you drop the transmission rate by half, in 6 weeks, this disease would be much, much, much lower than it is now. And so I hope it's going to be soon. But again, with everything, with testing, back in March, we said, we're going to be able to do 1 million tests a week. We're still not there. Okay, so 2 questions here. Let me start first. I heard that wearing a mask doesn't keep you from getting sick, but it will keep the germs from getting out. There was a congressperson who said that last week, and it was like, oh my God, didn't you take high biology? So the story is, he suggested that somehow there were germs that got on the mask, and he got the germs, and then he couldn't expel them. That's not how it works. So the way it works is germs get in, and yes, you may expel germs to others, but the way you get rid of the disease is not by expelling the germs. And so he was a little, so masks are a good thing. Again, people have said, well, why isn't there a double-blind control study about masks? So a double-blind control study would be a study where neither the person who was getting the disease or the person who was treating the disease or observing could tell the difference in what goes on. So I've been involved in a number of these studies, and what they do is you get it, you randomize the patient, you say this patient should get the pill from bottle A, and the pill from bottle A looks exactly the same as the pill in bottle B. One has medicine and one is a placebo. So the patient doesn't know they're taking the medicine or the placebo, and I don't know if they're taking the medicine or the placebo. You couldn't do that with a mask, right? Because if I was wearing a mask, I could probably tell. And if you were wearing a mask, I could probably tell. So there's no double-blind control studies, and there never will be double-blind control studies of the mask. But there are so many good observational, engineering, mechanistic, and physics studies that show that masks do work. All right, so the question is, how much more likely is a type 1 diabetic child to get COVID than someone who's not diabetic? Type 2 diabetes, adult diabetes, is a real risk factor for this. I looked the last time, and type 1 diabetes was not a risk factor. I wasn't sure. In kids, I wasn't sure about that, but you could check it. So if you go CDC, and CDC has conditions that increase risk, and you can go and check on type 1 diabetes and actually find the original data. Yeah. So Gary said, is there any possibility that COVID hit here in November and February? Yeah, there's always a possibility. I'll never say no. But again, when they've done these studies and they've looked at antibodies in those times, when they've looked at isolates, so, they do isolates all the time for flu. And when they looked in flu isolates, they did not find this circulating in the United States before mid-January. And they didn't find much of it in Oregon until mid-February. So I don't think in November. The other thing that they have, which is really pretty amazing, is they have multiple full genetic sequences for this virus. And so with time, there are little changes in the virus, most of which are just nonsense and don't mean anything, some of which are important. And so you can sort of trace back to where it started. And they can trace these back really no earlier than mid-January in Seattle, and no earlier than mid-February in Oregon. And multiple different people have looked at this, and everybody has concluded the same, that it really doesn't appear to have been here before mid-February. And in Roseburg, we carefully looked at it. I mean, we didn't have any cases at the time, so we were looking like crazy. We don't think we had any cases until maybe we had a case in the end of February who got this at, again, another state and came in and got it, but we don't think it happened. Now, when the final results of all these, of the Seattle flu study comes out, we'll know exactly what the germs were, but I don't think so. So Debbie says, does the amount of layers in a mask matter? I see 3 and 4 layer masks being sold. So it turns out that with a mask, the more layers and the denser the layers are, the better the mask is. So, 4 layers, 5 layers, 6 layers, 8 layers, all make it better and better. But the more layers you have, the less airflow there is, the warmer it is inside the mask, and the more uncomfortable it is. And once you get past 3 layers, it doesn't really make a big difference. So the difference goes to like 95 to 95.2 or something. So it doesn't change that much, but the difference in comfort changes a lot. And what I tell people, any mask, even a 1-layer mask, is better than nothing. And so that's what we're asking people. So you remember a few months back I did this thing with spray cans. There was a guy much more adventurous than me. We'll link our thing here, who did this with spraying ether and a torch. And he showed pretty much the same thing, that the mask did a very good job of preventing explosive spray. And his was pretty impressive because he burned stuff along the way. Okay, a couple more things here. School reopening, again, we talked about. It looks like if we can keep our rates down, that we'll probably be open K3 in the fall. That would be good, but that requires that we all keep the rates down. Remember, avoid parties, careful about interstate travel, stay home if you're sick. The other thing that came out is 2 studies this week that looked at kids, right, because we're worried about them going to school. One was a study from Chicago that looked at the amount of virus in the nose of kids 0 to 5, 5 to 17, and adults. And kids 5 to 17 and adults had a moderate amount of virus. And we thought that actually kids 0 to 5 would have very less virus. They actually tended to have more virus, which was a little surprising because we don't think kids 0 to 5 spread it very much. So, it's a head scratcher. How do you have more virus but spread it less? So we're a little confused there. The second is Missouri opened camps. And Missouri had a lot of outbreaks in their camps. That is worrisome for opening schools because what kids do in camp is sort of similar to what they do in schools. Now, in this case, in the camps, the kids also ate and slept together. So that obviously could have far greater spread, but there was a lot of spread even among younger kids in camps, so that makes us worry a little bit. Other things that we have here, one more question? Okay, she's writing it for me now. All right, so keep your questions coming. In the summertime, I know on Fridays people like to be done early, and that's perfectly good with us. We may actually do a different format for Fridays in the future. So you don't see it here, but there's a team here that's helping me with the questions and such. And so I really want to give them Friday nights off so they can spend it with their families. So one of the questions is, what about the long-term issues from COVID if you don't die? This is very, very important. And this is important because for everyone who doesn't die of COVID, there are 5 or so that are in the ICU. And we think that people, especially in the ICU, have long-term damage. And I will probably leave one of the areas out, but starting from the top, I attended a seminar today about long-term brain issues. And the long-term brain issues are significant. Now, the virus we don't think gets into the brain itself, but the people who've been in the ICU for a while really have some long-term cognitive issues. So their memory, their recall, their ability to problem solve, their ability to go ahead and come up with new words is really hard in people who have this. So what we're afraid for people, especially with more severe COVID, is that they're going to have long-term cognitive issues. Now, again, that's not surprising. Again, most people in the ICU are older. We know that older people in the ICU, for any reason, will have some cognitive decline. And we certainly know that if you get intubated, you'll have some cognitive decline. And it certainly can't be good to be in a coma for 3 months. And so that there would be some long-term cognitive issues is not only not surprising, we don't know the amount of that. The second is heart inflammation. And there are some concerns about heart inflammation in the time after you have the disease. And a pro athlete just this week was diagnosed with it. That is some heart disease that happens afterwards. We're not exactly sure why it happens or how it happens, but it has been noted multiple times. The next is kidney disease. Many of the people who wind up in the ICU wind up with kidney failure and wind up on dialysis, so that in many of the big hospitals, they are just straining to go ahead and produce all the dialysis. Some of the people get their kidney function back, but most don't. And so we're going to have a whole lot of people who now have kidney failure and need to have dialysis or a kidney transplant. Knowing people who are in that situation, that is no fun. Having to do dialysis a few times a week, waiting for a kidney transplant is really, really going to be bad. And this is going to tremendously increase the number of people with kidney failure. And then the last is the lungs. Again, we don't know about the long-term stuff in the lungs, but we do know in the people who died, and we look at their lungs on pathology, they look terrible. And there was a story on the news last night about a young woman who had COVID and was so sick they couldn't get her off the ventilator. She didn't have a lot of other damage other than she had terrible lungs. So while she was still in this coma, they did a lung transplant. So she had a lung transplant while she was in this coma. So she went into the hospital, said she was short of breath, and then was in a coma for several months. And while she was in the coma, they did a lung transplant. Once they did the lung transplant, her lungs were pretty good. And she was able to recover, and now she's out of the hospital and doing okay. So, we think there are going to be some long-term lung problems. And we think that even people with mild disease have abnormal chest CTs. This is really weird. People who were otherwise totally asymptomatic but had a positive COVID test, if you do a CT scan on them, many of them will have abnormal CT scans. That's weird, because usually you would think your CT scan, you'd have to be pretty sick otherwise with cough or shortness of breath to get an abnormal CT scan. Yet they do. So long term, we don't know what's going to happen. We think the lung damage is going to be there. We don't know how significant. The heart damage is going to be there. The kidney damage, we're pretty sure, is going to be long lasting and pretty terrible. And we're not sure about the brain. So that's worrisome. All right. So Wendy says, what therapies look most promising to you? What would you do for your 93-year-old mom? Well, I was a little late today because I was on the phone with my 90-year-old mom. She hasn't been out of the house since March. And, she doesn't let anybody visit. And, she talks on the phone all the time. But she does that. So really the best thing for a 93-year-old is avoidance. Once you're 93 years old, your risk of death from COVID is at least 15% or maybe even higher. And by the time you're 90, almost everybody has underlying conditions. And for that reason, the very best thing is prevention. In terms of treatments, there are 3 treatments that we think are successful. One is convalescent plasma. That's blood drawn from people who've recovered from the disease, injected into people who have the disease. We think that's probably a bit effective. Decadron or dexamethasone, which is a steroid, we think is effective for people who are who need oxygen or need ventilation. We think that helps to decrease the death rate. And remdesivir, which is an antiviral drug, we think is effective in decreasing the length of stay of hospitalization and maybe slightly decreasing the death rate. So all of those things, those are the 3 things. None of those are that great. So when we talk about these in baseball terms, staying home is a winner every time. Remdesivir is a bunt single. Decadron is maybe a double, but there's nothing out there which is great. Now, we wish there was. We've heard about this guy with the inhaled budesonide. We've heard about the hydroxychloroquine. Really, truly, if there was something out there that worked, there's no politics in the world would make me not do it. But really, having looked at this, it looks like it just doesn't work. And it's sad that 3 months later we're having such anger about something which I think is already solved. Okay, that's it for questions. That's great. But we'll do this again on Tuesday night. Again, Dr. Bob Dannenhoffer. Just a couple things I would say. One is be really careful about travel. If somebody's coming to visit here, maybe they could put it off. If they can't put it off, really ask them if they could get here, quarantine for 2 weeks. And you could quarantine for 2 weeks very safely. Rent a cabin at Diamond Lake, rent a cabin on the river. Enjoy that. As long as you're not around other people, you can still enjoy much of what goes on in Oregon. After 2 weeks, you don't have the disease. You can come and visit all you want. If you can't quarantine for 2 weeks, maybe think about not going. If you do have a trip planned somewhere, really, really plan to quarantine 2 weeks on the way back. So that in our cases, if the cases where people brought it back to town, if they had done that, they wouldn't have spread it as they did. So really think about quarantining. The second is really worry about gatherings, because the bigger the gatherings get, the chance that there's going to be one or more people there who are infected really increases, and the chance for a super spreader effect goes up exponentially. So you really, really need to be careful about gatherings because gatherings are dangerous. One of the sad things this week was the death of Herman Cain. I think Herman Cain was really quite an unusual guy and really brought a lot of fresh air, I think, to the thing. And it really looks like he got this disease either sometime on the weekend of the Trump rally, whether he got it at the Trump rally or the day before or the day after. I don't know, but this was a bright light in politics who was the same age as the president, younger than Biden, who got this, spent a month in the hospital, and then died. So really, really be careful about gatherings. Wear a mask when you're out. Masks aren't perfect, but they're a whole lot better than not wearing masks. Wash your hands. And most important, be kind. I actually got to do one of the case investigations this week, and I will tell you, people were way kind. It was so great. People, talked to us about what their contacts were. We asked some complicated questions and sometimes some embarrassing questions, and people were great about helping us out with that, getting us the names and numbers of contacts, agreeing to quarantine if they did it. So thank you for people doing that. There are places in the country where that does not happen, and it's one of the great things about Douglas County. All right, if there are no more questions, this is Dr. Bob Dannenhoffer, Public Health Officer for Douglas County. We'll see you again on Tuesday night.